Hello, everyone. Thank you for joining. As we're waiting for everyone to join, please feel free to say in the chat where you guys are watching from. We're from sunny California, Riverside, California. It's been hot recently, but it cooled down a little bit today.
I can't even see the chat. No, is our group not the same group as what they're in? Are they in a different group?
It's a good question.
Okay. I don't see any of their responses. Oh, there we go.
Sorry, Dr. Fogelson, there's two panels. There's panelists and then attendees. And then you'll be
You're starting to see some more people now.
Temecula in Oklahoma. All right. So we're going to go ahead and get started. So good afternoon, everyone. Welcome to the Endometriosis Family Support Group webinar. My name is Serenity Patterson, and I'm the Foundation Intern with Riverside Medical Clinic Charitable Foundation. First off, I would like to go ahead and thank our wonderful sponsor, the Riverside Medical Clinic and Abib. We truly appreciate their support. There will be a short Q&A portion towards the end of the webinar, so feel free to add any of your questions or comments for our presenter in the chat box to the right or below the presentation. I would like to introduce our presenter for today, Dr. Nicholas Fogelson. Dr. Nicholas Fogelson is a physician and surgeon in practice in Portland, Oregon at Northwest Endometriosis and Pelvic Surgery, where he specializes in surgical care for people with endometriosis and other complex pelvic pain conditions. He has been practicing for nearly 20 years and has focused exclusively on endometriosis and pelvic pain since 2015. I will go ahead and give it away to Dr. Nicholas Fogelson.
Hi, how are you? Am I on? It looks like you're still on now. You want to switch over to me? Serenity, I think you're the one that is being shown, not me.
No, you're on, Dr. Fogelson. You're the only one being shown.
Oh, okay, great. Hey, everybody. My name is Nicholas Fogelson. I'm a surgeon in Portland, Oregon. I actually grew up here in Oregon and traveled around the world during surgical and medical training, but eventually came back here, and in 2015 came back to Portland. And 3 years ago started a medical practice called Northwest Endometriosis and Pelvic Surgery, which is my own practice. And just recently added Dr. Shanti Moling into my practice, who I think gave you guys a talk on intergender, transgender care and endometriosis a few months ago as well. So I'm really happy that the foundation asked me to speak. I wanted to kind of talk about a topic that I am interested in and I know a lot about. I do endometriosis surgery of all types. I do, of course, excisional surgery is kind of what we believe in and really excising endometriosis rather than ablating it if we're going to do surgery. But we do, bowel endometriosis and thoracic endometriosis and all kinds of stuff. But what I wanted to talk about today was an interesting entity called abdominal wall endometriosis. I'll tell you an interesting story. So the story of abdominal wall endometriosis for me is actually the story of how I got an endometriosis, which is really kind of interesting. I was in my first ever academic position in 2005. I was at the University of Hawaii in Honolulu, and I was actually in a little outlying clinic in Kapolei, called the Kapolei Clinic, which is part of like a big outlying center called the Waianae Health System. And I had a patient who I came in to see, and she was in terrible pain. And she says, I have this mass in my abdominal wall. It's like I have this thing and I keep going to different doctors and nobody will do anything about it, but it's just unbelievably painful. Like, is something you can do about it? And I saw her and I felt her abdomen, and she literally had a knot about that big in her abdominal wall. And it was very clearly in the abdominal wall itself. It wasn't in her belly, it was in the meat of the abdominal wall. And it was extraordinarily tender. And I touched it, she just jumped off the table. It was so painful. And I had a recollection to being told in residency when I did some endometriosis surgery in residency, not a lot, but I had one particular mentor named Paul Underwood, who was a cancer surgeon that kind of taught me about excising endometriosis. And he told me one day about abdominal endometriosis. I'd never actually seen it, but at this point in my career, I saw this woman and I said, you know what? I think this thing is abdominal endometriosis. So I literally took her to the operating room that day and I removed this mass. And sure enough, it was abdominal endometriosis. And she was completely better and I was hooked. I was like, wow, this is an interesting condition that is very treatable. And she was very appreciative because interestingly, like a lot of people with abdominal endometriosis don't get diagnosed by doctors very easily. So let's talk about kind of what it is, first of all. A lot of people know endometriosis is when you have tissue outside of the uterus that's kind of like the lining of the uterus. It may not be exactly like the lining of the uterus, but it's pretty close. And endometrium is the lining of the uterus. Endometriosis is then just in Latin, meaning that you have endometrium outside of the uterus. And over time, we've come to realize the tissue outside of the uterus is not exactly like the tissue on the inside of the uterus, but it's pretty close. So if you have tissue on the inside of the pelvis, we call that peritoneal endometriosis, and that's the fairly typical type of endometriosis that people have when they say that they have endometriosis. But there's this other condition, which is called abdominal endometriosis. It's also sometimes called cutaneous endometriosis. And that's when you actually have a lesion of endometriosis usually within muscle or within the fat of the abdominal wall, or sometimes within the fascia of the abdominal wall. And the fascia is this really thick covering that we have that kind of holds all our guts in. And if you get cut through your skin and it doesn't go through the fascia, then you just have a wound and you can suture it and everything's going to be fine. But if you get cut through the fascia, then your guts can spill out, basically. So that's the part that really holds everything in. And so you can get abdominal endometriosis in the fascia, and it's very painful. And the way it characteristically presents is that a person who has this condition will say that they have a really severe pain, usually in their abdominal wall, and they feel it during their menstrual cycle. It gets really, really painful. And it can be extraordinarily painful to where you just barely touch it and it just sends them through the roof. It's so painful. In some cases, there will be a mass that is above the fascia. So when you touch on the skin, you can actually feel it and you can feel kind of like a lump in their abdominal wall. In some cases, you actually can't feel it. And the reason why you can't feel it is that there's a fascia, like we talked about, but the disease is under the fascia. So the first thing you feel is this pretty tough fascia. And when you push from the outside, it just kind of goes like this. And even though the mass is here, you just kind of push and all you feel is the fascia. So it's tender when you push, but you don't really feel this mass. And I've seen quite a few patients that I've operated on that other surgeons have said, well, you can't have this because I can't feel anything. But the reality is that it's underneath the fascia, and that's why they can't feel it. I've also operated on people that had surgery from previous surgeons who kind of cut endometriosis off above the fascia, but never went below it. And so there was disease left underneath, and we'll actually show you a case like that. And so there's two kinds of abdominal endometriosis. I think the vast majority of these are what we call an iatrogenic implantation of endometriosis, which means that some doctor put it there, a surgeon put it there. And the way it usually gets there is because someone had a cesarean delivery. And when you do a cesarean delivery, you make a hole in the uterus and the baby comes out of the hole, but then the lining of the uterus, which is the endometrium, is kind of free in there. And if a little piece of that endometrium gets dislodged, and then when the surgeon's not cleaning up quite well enough, and that piece of endometrium gets stuck into the abdominal wall as the layers are being closed, then that's a setup for abdominal endometriosis. Some people also get abdominal endometriosis in port sites from laparoscopy, particularly if a surgeon takes a piece of endometriosis they removed and they kind of pull it through the skin rather than keeping it in a bag or keeping it in the port, and they potentially can seed the wall of the abdominal wall with the endometriosis, and then you get a lesion there. I've also seen patients who had what we call uterine morcellation, where someone was doing a hysterectomy and they chopped the uterus up into little bits to get it out through laparoscope ports. which we no longer really do anymore. We do it differently, but in the past, that used to be done in a way that it was totally free in the belly, and you would cut up the uterus in a little bit. So you can imagine small pieces of the uterus kind of being free and potentially getting caught in the wall of the abdomen. And if it has endometrium, then you can get an abdominal wall endometrioma. So I think that most abdominal wall endometriosis is caused that way. And the classic presentation is a person has a lump in their cesarean scar that gets really painful every month. And I mean, that's probably 4 out of 5 abdominal wall cases I see are post-cesarean section abdominal wall endometriosis. And it usually presents itself 12 to 18 months after the delivery, usually coinciding with when the woman stops breastfeeding. Because when you breastfeed, your estrogen levels tend to be pretty low. And so often there's not a lot of symptoms until the woman or a person stops breastfeeding. And then that disease becomes more symptomatic. And then the patient may present and say, I have this problem. Unfortunately, it doesn't get diagnosed very frequently. Frequently, physicians don't know what it is. If they go and see a general surgeon, a lot of times a general surgeon will see this mass and they're worried that it's cancerous, and they'll biopsy it, and they'll say, well, it's just endometriosis, there's nothing to do about it. Or they'll say, we'll put you on birth control pills or something. I've literally seen that where people had symptomatic abdominal wall endometriosis, but the surgeon can only imagine that it's not a cancer, so I don't care. When the reality is it's extraordinarily painful and it's very responsive to surgery. And so if a surgeon finds that mass in there and they identify it as abdominal endometriosis, then if that surgeon's comfortable with it, hopefully they will do a surgery to remove it, or if not, they'll refer it to someone who is. And really, abdominal endometriosis is not that hard to remove. It's more of like an intellectual understanding of how you do it, but how you do it is not that difficult. It pretty much involves cutting a mass out of the abdominal wall and then repairing the hole that is left. And in some cases, that means that the layers that you cut into can just be put back together. And in some cases, you leave enough of a defect in the abdominal wall from removing it, because some of these things can get pretty big, that you end up having to repair that with some sort of other material. And I'll show you some of those cases as well, as sometimes you have to put a mesh in there, or in really big cases, you could even have to put a piece of muscle in there from somewhere else. Now, there's another entire type of abdominal endometriosis that's truly spontaneous, where a person is born with it. It doesn't seem to have been put there by any sort of surgery. And that's, we don't entirely understand why that happens. It's probably by the same mechanism that people get endometriosis in the pelvis in the first place, that some area in that tissue is sort of set up to become endometriosis one day, and then eventually it grows. And the classic sign of that is a person who says they bleed out of their umbilicus every month. I've had probably 5 or 6 patients in my career that says they have a menstrual cycle coming out of their umbilicus. And they often think that they're literally menstruating through their umbilicus or their belly button, but they're not. Their menstrual flow is going out their vagina, but there's actually endometriosis in the umbilicus, and it bleeds every month. So it's almost like they're having another menstrual cycle coming out of the umbilicus. The other thing that kind of brings to light is that abdominal endometriosis and pelvic endometriosis is really a different disease state, because pelvic endometriosis lesions don't bleed profusely every month, but abdominal wall lesions do bleed. And it is probably because they literally are endometrium. It's not the quote endometrium-like tissue that people that have peritoneal endometriosis get, but it is literally endometrium stuck in the abdominal wall. And so it bleeds just like the inside of the uterus does. So I'm going to show you guys some pictures of what these things look like. As I tend to do in presentations, I'm going to show you pictures of surgery, so hopefully you're not too grossed out. If you are, then I guess don't watch this part. But we're going to show you some open abdominal wall endometriosis cases, and I'm also going to show you some laparoscopic abdominal wall endometriosis cases. So I'm going to go ahead and share my screen and show you guys what that looks like. And just going to give you a little bit of an overview of abdominal endometriosis, and mostly this is going to be pictures. The first case I was going to talk about is the kind of classic thing that we just mentioned, which is a patient or a person complains of painful swelling in her abdomen. This one had swelling in her left side of her abdomen, and it was near her cesarean scar, and she had a previous cesarean delivery. And this is a CAT scan of what that looks like. When you look at a CAT scan, it's like a slice through a sausage. So if you imagine you bought a pepperoni at the market and you sliced it, basically you're slicing a human being that way. And that's what we're looking right here. And in this picture, the person's feet are coming out towards us, the person's head are going away from us. And then if you imagine them lying in a tube that way, that means the left side of our screen is the patient's right, and the right side of our screen is the patient's left. And you can actually see that R over there, that's where the right is. So you can see, I was hoping to have a pointer that I can show you, but I can't seem to give you a pointer. Let me see if there's any way. Doesn't seem so. So there, basically, the very top of that CAT scan, you see the patient's skin. And then as you come down, you see a bunch of just black stuff, which is fat. And then you see that first thin layer kind of across the middle, that's the fascia. So that's that thick covering that holds everything in. And all the stuff on the inside is the patient's guts. Those black areas are air that's in the bowel, actually. And the white area is the bones of the pelvis. And so you see that kind of ball that red arrow is pointing to, that is abdominal wall endometriosis. And when you get a CAT scan, you don't get a letters and an arrow like that. I put that later. So that's why the person has to read it. So that ball there is abdominal wall endometriosis. And it's really quite classic. Like if a patient has recurrent abdominal wall pain with their cycle and you have a CAT scan like that, it's abdominal wall endometriosis every time. So this is what it looks like taking that out. You can see that this is on the left side of the patient's abdomen. This is the left side of their abdomen here. And that thing that I have in my instrument there is called a towel clamp, is right through the lesion. And basically, in this case, it's going all the way through the fascia. You can see sort of at the bottom of that hole, you see kind of like a dark red area. That's actually the muscles of the abdominal wall. And then that little kind of wider line kind of going a little diagonally just above it, that's actually the fascia. And so this mass that is being pulled out is going all the way through the fascia. And usually in order to remove it, you have to actually cut through the fascia and leave a hole in the fascia. And in this case, we actually did leave a hole, and then we took a piece of biologic mesh and sutured it in there. And the body is going to kind of absorb that mesh and create new scar tissue in order to kind of recreate the fascia. And it's probably not as strong as it was in the beginning, but it is stronger than just leaving it open. One of the concerns when you make a hole in the fascia is you're setting a person up to have a hernia. So if the hole is really small, you can just close it. But if it's big enough, we often will put a piece of material in there. And so this material is actually made out of the heart of a I think it's a cow pericardium. So it's actually the skin on the outside of a cow's heart is what this material is made out of. And then there's another material that's made from a pig too, that we use sometimes. You can also put synthetic material that is totally, synthetic, not from any animal. This sort of animal material will actually get absorbed over time, so it's not going to be there forever. Whereas if we use a synthetic material, it's going to be there basically forever. And this is what the abdominal wall endometriosis looks like. I will tell you, which you'll have to believe me, that this looks totally different than peritoneal endometriosis. Like we do not see big masses like this in peritoneal endometriosis. Whereas abdominal endometriosis, you see things that are quite large, and this is, it's a good 4 or 5 centimeters across. And you can see there's a bunch of fat around it because we want to make a nice wide margin around it to make sure we get the entire thing. And as long as we get the entire thing, they rarely recur. And these are very satisfying surgeries to do because, the cure rate's 100%. And as long as you do the surgery right, they're always better. There's almost never have any recurrence. That being said, about 50% of the patients I do have been operated on before. And it's because the surgeon really didn't completely get it out. People are not really aggressive enough. And so for that reason, I end up doing a lot of redo ones. We'll show you another case. This is another one, sort of similar, but it's in a different location. Now this time we're looking at an MRI instead of a CAT scan. It's still that same slice through the belly, kind of like a sausage, but we're a little bit further down. You can actually see the uterus, that kind of heart-shaped thing in the middle, that's the uterus. So this big mass, that white arrow that I put on there, again, that's abdominal wall endometriosis. And this time it's almost completely replacing the rectus muscle. So there's to the left of that mass, you see kind of a black blob, and that's the left side, or actually the right side of the patient's rectus muscle. And then the left side of the patient's rectus muscle And again, I say left and right because they're switched because the patient's feet are towards us. That left side's actually been completely replaced by that endometriosis. And again, here we see it in a different section. This is where the slice is basically, it's called a coronal view. So you can imagine that the slice is almost from your back to your belly button. It's sort of the plane of the slice. And you can see that abdominal endometriosis in the front, and that's the rectus muscle. And then that's the rectus muscle that's basically replaced. And then that kind of other oval area down below it is actually the pubic bone. And then just to the right of it is the uterus. And you can kind of see the colon and the vagina to the right of that too. So this is that mass coming out. It is actually, that's a different patient because it's clearly not the same person, but this is that mass coming out. It's pretty large. I mean, this is quite a large abdominal endometriosis, and the whole, that white kind of furry edge that you see there is actually the fascia that's been cut through. And this is the mass coming out. You can see on the right side, there's that clamp on the mass, and it's really quite large. Now, this is once the mass is completely gone. And basically what we're looking at is the bladder, this glistening area kind of on the bottom of the incision on the inside. That's the surface of the bladder. So we've completely cut through. You see kind of fragments of that dark purplish muscle that's been removed. So that whole rectus muscle has been removed, and you see the bladder completely poking through there. So if you didn't fix it, you'd have a hernia for sure, and you'd have your bladder almost herniating up into the incision. So we have to fix it. So in this case, we're going to put a piece of synthetic mesh, and this mesh is being tied down onto the pubic bone, onto something called Cooper's ligament, which is a kind of a ligamentous attachment between the muscle and the bone of the pubic bone. And then what we do is we pull that mesh up underneath the residual part of the muscle, and it's almost like if you were to patch, if you had a hole in your clothes, like your child had a hole in their knees, and you were going to put a patch on the inside of your pants in order to close the hole. This patch is almost on the inside of the hole, and then we're going to pull the muscle here. You can see the muscle being pulled over, and the muscle has now been completely pulled over the top of the mesh. So this keeps the mesh from ever contacting the skin, and the mesh is also above the peritoneum. So the mesh is not going to be in contact with the bowel. It's not going to be in contact with the skin, and it's not going to get infected. It's not going to move, and she's going to have a really good durable repair from that. She is missing a little bit of muscle, but she will do okay with that. It's certainly in the case when there's a big abdominal wall endometrioma, you're better off losing some muscle than not removing the endometrioma. So again, what I was mentioning about other surgeons occasionally not doing the case right is that they're not aggressive enough. Like in this case, we had to remove a big piece of muscle in order to do this, but you just have to do it. Like if you say I'm not going to remove it because I'm worried about removing X or Y structure, it's going to be a failure of a surgery. So you may as well not operate. So you just got to remove all the endometriotic tissue and then repair whatever's left. And so in this case, we put a piece of mesh. And you can see this is the incision when it's done. It's really not very big. And if you look to the left side of that incision, you can see the scar of her cesarean section. So basically we've opened up about 3/4 of the cesarean scar we've reopened. And you're not even going to be able to tell eventually because the scar is the same scar she had for her cesarean delivery. So you're not even really know in the future that she had the surgery. And that's how big that mass was. It's about 5 or 6 centimeters across, really quite large. And again, it looks just like that other one when you cut it open. You can see small little black pits in there. Those are little areas of bleeding where the endometriosis is bleeding. And every month, sometimes these things will bleed into the abdomen. You can get bruising sometimes. So pretty gnarly. This is another one that's actually a video that I'm going to show you where she had pain in her left abdominal wall. She had a hysterectomy, and she'd actually had her uterus morcellated. And she ended up having this big mass in the left side of her pelvis, and another surgeon operated on her to take out that mass. And I think what it was actually a piece of her uterus that had been left in there. And she ended up developing endometrioma in the port site from when they removed that mass. And the previous surgeon actually removed endometriosis from the top of the mass, top of this fascia, but he never went below the fascia, and the patient still had pain. So I'm going to show you, I'm going to kind of skip through the video a little bit because it's a little longer than we want, but this was a video that we actually presented, and I believe it was actually the first ever abdominal wall endometriosis that was ever presented Okay, so this was the first ever video presented of laparoscopically managed abdominal endometriosis that we've ever seen in the literature that we presented. This is again is an MRI. It's cut what we call sagittally, which means it's cut shoulder to shoulder, basically. This is guts here, but right here, this is the rectus muscle, and this right here is endometriosis, and that's exactly where she had pain. So we knew that, oh, shoot. I did that wrong.
Thank you, AAGL, for the parametric
To get you back to that picture.
at the site of the more left.
Okay, so this is the same patient, but with a different projection on the MRI. And you can see this is the oblique muscles, this is the rectus muscle, and this is the endometriosis right here in the abdominal wall. And so,
Thank you to the AAGL for allowing us.
Thank you, AAGL. This is the more midline.
Okay, so this is surgery being done robotically, and man.
Thank you, AAGL, to demonstrate the fully laparoscopic.
So this is actually this lesion from the underneath side, and rather than operating from the outside in order to remove this, because this lesion is under the fascia, we're operating laparoscopically, and this is a robotic instrument. It's a Da Vinci robot we're using, and this is sped up a little bit. I don't operate that fast, but with the magic of movie making, we can make me seem like a faster surgeon. But the you can see that we were able to remove this mass, and this patient just had total relief of her pain. There's that brown stuff coming out. When we cut through deep infiltrating endometriosis, you'll have that brown kind of gnarly stuff come out. And that's part of how we know things are endo, because it's all brown. And in this particular case, she had been dealing with this for about 5 years, where a previous surgeon had operated, and 5 years had gone past where she still had pain. And the previous surgeon said, I already removed it. There's nothing more to do. And ultimately, there was something more to do. It was just all under the fascia, and that previous surgeon just didn't quite put two and two together, I guess. There is a saying that I was taught when I was a resident, which was that the eyes don't see what the mind don't know. And I was trained in the South, so they're grammatically incorrect slightly. So the eyes don't see what the mind don't know, which means that there was nothing hard about seeing that this lesion was there on the imaging. It's just a matter of, like, if you don't know that the lesion could be under the fascia, then the previous surgeon had removed it from above the fascia, and they thought they had already dealt with it, and the patient still had symptoms. And then the surgeon says, well, the patient's crazy or whatever, they don't know what to do. But if you realize that it could be under the fascia, then the whole thing is fairly clear. So as a doctor that studies pelvic pain and does different things, like it's every bit as important for me to read books and study literature and as it is to practice surgery, because knowing about a particular kind of situation, about what's going to happen and what kind of things will work, is ultimately the beginning of being a doctor. It's not just about knowing how to operate. Like if you don't know how to operate, you can't operate. But if you don't know when to operate and you don't know what to do in surgery, then you can be the best surgeon in the world, and you won't help people as much because you'll not do the right surgery at the right time. So in this particular case, fortunately, we were able to figure out that she had this lesion underneath her abdomen, and she was just way better. She's a really nice lady, and was really happy with the result. So we'll show you one more. This one is similar. This one is in a little bit different location. I don't think there was imaging on this one, but there's actually a mass in the abdominal wall, which is similar. And in this case, we didn't use the robot. This is with traditional laparoscopy. And in this case, the patient had not been operated on before, but it was fairly apparent what was going on. And also, you can see the difference between traditional laparoscopy and robotics. These instruments don't articulate like the robot does. And really, the robot provides a tremendous advantage in our precision and how we can operate it. If you can see between these two videos, just the ability to be very, very precise in what we're doing and have very, very fine motion is much better with the robot than it is without it. But in this particular case, we didn't have the robot available, I guess. So this is the mass here that's coming out in the abdominal wall. And Eventually, we're going to get it completely out. This is another instrument called a harmonic scalpel that it's good for cutting through muscle because it'll seal it and it won't bleed. And we're using that. And finally, you're kind of getting underneath this whole mass. And again, you see this brown stuff coming out from the mass there. And this is the fascia I mentioned. This white tissue is the fascia. That's the part that kind of holds everything in your abdomen. And when people talk about hernias, a hernia means you have a hole in the fascia. And because there's a lot of pressure in the abdomen, if you have a hole in the fascia, there will be a tendency for things to poke through there. So your abdominal fat can poke through there, your bowel can poke through there. And like when men have a hole in their fascia in their groin, they can get stuff poking into their scrotum, actually. That's a kind of an inguinal hernia. And then women sometimes can get hernias in their groin also. And usually nothing pokes through, but they can get pain sometimes. And so this fascia is actually intact. There's no hernia, but we've removed a bunch of this muscle. And so we're going to kind of pull the muscle together. This is a barbed suture. And so barbed sutures are nice because you don't have to tie knots. You can kind of pull them together and they'll stay tight. And now we've kind of repaired the abdominal wall to the best we can. And a lot of times, in this case, you can see we're not getting it completely together, but the abdomen will just heal and eventually it'll kind of just heal together. And this patient did great. She had total resolution of her pain also. Again, abdominal wall cases are, as a surgeon, I really like these cases because, for one, I've gotten really good at doing them, and which is nice to do something you're good at. But it's a case where like knowledge is power. It's not that hard to do the surgery. Like other kinds of endometriosis surgeries I do are much more technically difficult. And you have to practice the technicality of how to do it right. Abdominal wall endometriosis is not really that hard, but you have to understand the condition. You have to understand what you're trying to do. And a lot of these surgeries fail, not because the surgeon's not a good surgeon, but because they just don't quite understand the condition well enough. And so I like this because I've studied it, become comfortable with it. I see enough of the cases because I'm a little bit known for it. So I see more of the cases than a lot of people do. And it's great because if anyone that are listening that have had peritoneal endometriosis surgery, excisional surgery in the pelvis is, fairly effective at removing endometriosis and helping with pain, but it's not perfect. Some people have recurrent pain, some people have recurrent endometriosis despite the best possible surgeries we can do. But abdominal wall cases are not like that. They're 100% curable. And like, I know when a patient comes in with abdominal endometriosis that I'm going to cure her of that problem. And that's a very nice thing as a surgeon to feel that I don't really have any uncertainty about it. I can confidently tell her that after I'm done operating and once you've recovered, this problem is going to be just completely behind you. And you can't necessarily say that with sort of widespread peritoneal endometriosis. And so it's a cool condition. It's a weird condition. A lot of doctors don't know very much about it, but if a person has like a mass or a knot in the abdominal wall and every single month it's extraordinarily painful, this is probably what it is. And before I kind of stop and maybe take a few questions, there is this kind of idea of something called a pre-test probability and a post-test probability that surgeons get confused with, or doctors get confused with. There's a lot of conditions that are sort of, quote, rare. I know if any of you know Wendy Bingham, she has a group called extra pelvic endometriosis, not rare. She's making the point that this isn't as rare as you think. Well, abdominal endometriosis is rare in that if you see 10,000 random patients with random complaints, and they have all kinds of different complaints, maybe none of them have abdominal endometriosis, or one of them does. Like, it's not a very common condition. And so what we call that is the pre-test probability, that before you ever add in their symptoms, the likelihood a given person is going to get X condition is very low. So it is, quote, rare. But when you add on a person that has a palpable mass in their abdominal wall, and they have cyclic pain in that mass, and maybe they had a cesarean section before, they had some sort of surgery that might have given it, like, it's not rare anymore. It's now very, very common. And in fact, when you see that set of symptoms and that set of physical exams, it's 100% certain that they have abdominal wall endometriosis until proven otherwise. And chances are it's not going to be proven otherwise. It's going to be proven true. So a lot of doctors get confused between pre-test, post-test probability, where they say this condition's really rare. So it must not be that. And they don't take into account the fact that the patient has the perfect set of symptoms for that rare condition. And the same can be said for a patient that has cyclic pain in their shoulder and they have bad pelvic endometriosis. Yes, thoracic endometriosis is rare, but the patient that has shortness of breath and cyclic pain in their shoulder, who also has bad pelvic endometriosis, it's not rare that they have disease in their diaphragm. It's actually quite common. So again, this difference between pre-test and post-test probability is really important. And I think a lot of the patients with abdominal endometriosis take a long time to get diagnosed because either the physicians have no idea about the condition at all, or they end up working with like a general surgeon that doesn't have a very good sense of the condition and they don't cut it out widely enough. Or the person has a perception of the condition, but they say like, well, I've been in practice 15 years. I've never seen that. So why would I see it today? It's so rare. And yet the patient that has the perfect story for it actually has a 100% chance of having it or 90% chance of having it. So, in order to be the best physician you can be, you really have to take into account not just how rare something is from an overall point of view, but really how characteristic does a particular patient's symptoms and maybe their findings and imaging and so forth. Like once you put all that into it, now how rare is it? And chances are it's not rare at all. The classic thing about women with heart attacks is the same, is that if a man goes to an ER with crushing substernal chest pain, he'll be diagnosed with having a heart attack very quickly. But if a woman goes to the ER with the exact same symptoms, chances are they will take a lot longer to come to the diagnosis because heart attacks are less common in women. There's no question that heart attacks are less common in women than they are in men. But when a woman has the perfect set of symptoms for a heart attack, she's still having a heart attack. So you have to take into account, exactly how a patient presents. So we've been going for about a half hour. I'd love to take some questions. I'm happy to take questions about other areas of endometriosis. Of course, this is a very narrow little area of endometriosis that I know a lot about. I know about other things too, but it's an interesting thing to present, and I'm glad you all had an opportunity to watch it, and would love to hear any questions that you all may have.
So thank you for sharing. You shared a lot of great and informative information. We had some questions that came in beforehand. So we have a question that's a two-part question. And the question is it common for endo implants to get spread to the abdominal wall or elsewhere during surgery?
Well, it's a great question. I don't think it's common, but it does happen. There are things you should do to prevent that as a surgeon. The one thing you should never do is take a piece of endometriosis and pull it through the abdominal wall, not in a port. And I've seen surgeons do that. I've seen videos of people doing that, where they get some like tiny chunk of endometriosis, maybe the port slid out. So the port is the little plastic sleeve that goes through the abdominal wall, and then the instrument goes through that port. So you probably don't know, but sometimes these ports will dislodge themselves, and sometimes they'll kind of slide out. And there are circumstances where sometimes the instrument's going through the abdominal wall and the port is kind of slid out over the top of the instrument. And so a surgeon will get a chunk of endometriosis and they'll basically not put the port back in and then pull the disease through the abdominal wall. That's a perfect setup to leave some microscopic little piece of endo in the abdominal wall, and then it's going to grow and become a lesion. The other thing that I think happens sometimes is, again, cesarean sections, like the really big one, because you actually have an exposed endometrium during a cesarean section. And I think what's really important is that the surgeon washes things out really thoroughly and make sure they get all the little bits of debris out before they close the abdominal wall. And I think some people are more thorough at that than others. I also think it's important that surgeons close the peritoneum. There's a layer of skin on the inside of the abdomen called the peritoneum. And like classically, general OBGYNs are taught that you don't have to close it. And it's true that if you don't close it, it'll eventually heal. And there's a bunch of papers that say you don't need to close it, but I think those papers are flawed for a number of reasons. I think that if they don't close it, you have an opportunity for that open edge of the uterus. So you have something called a hysterotomy, which is the hole in the uterus. A lot of times it's kind of everted, and little bits of the endometrium are kind of showing on the outside of the uterus. And now if the abdominal wall is here and the uterus is here, and they didn't close the peritoneum, so there's like a gap in the top of the abdominal wall. And now that uterus is like sticking there, and that endometrium can grow into the wall. And I've actually seen cases where the uterus was completely fused to the abdominal wall, and there was a big knot of abdominal endometriosis. And as we were removing the abdominal endometriosis, literally the uterus was stuck to it and it had to come out with it. In fact, just in case, this is, in fact, here's a picture of it. I happen to have it right here. So right here, this is a big chunk of abdominal wall endometriosis, and here's a uterus. So basically, this patient probably had a classical cesarean section where they had to cut over the top of the uterus, and sometimes they do that, the baby's breech or premature, and it just got fused to the abdominal wall. This is the fascia right here. This is this huge piece of abdominal wall endometriosis. And so basically, as this was being removed, you couldn't get it off the uterus, so the patient had a hysterectomy also. So fortunately, she was done having kids. But so the question being, how common is it? Again, it's not that common, but if you had the surgery and you had the perfect set of symptoms, then it's going to be common in you. That's the answer.
And the second part of that question was, what screening questions do you recommend asking when speaking with a specialist concerning their skill?
Well, that's a really good question. I may give you kind of a complex answer, because I occasionally have patients that contact me with a set of kind of litmus test questions that they get from online. And internally I go like, I'm going to give you the answers that the online tells you what you want to hear, because I 99% agree with them. But the reality is these litmus test questions are always very, very simple questions that it's like, if you really understand this stuff, it's more complicated than the litmus test answer. Like, do you excise an endometriosis or do you ablate it? It's like, well, you should excise it. But anybody that tells you they excise 100% of all endometriosis is not telling the truth. Like, there are some kinds of endometriosis you can't excise for various reasons. So like the complex answer is more real than the litmus test, yes, I excise endometriosis. So let me give you some general questions. In general, I'm just going to throw this out for any procedure. A surgeon should do a lot of it, which meaning that how often do they remove abdominal wall endometriosis? Well, if they've never done it, they are not very experienced at it. That doesn't necessarily mean they can't do it well. Like, if they intellectually understand what they're trying to do, they may be able to do it fine. But in general, someone that does something frequently is going to be better at someone that does something infrequently. The same goes for all kinds of endometriosis. Like, if you have bowel endometriosis, you are much better served by working with someone that does bowel cases frequently. Like, I do bowel surgery 3 or 4 times a month, sometimes more, and we have very few complications. If it's something that you do once a year, your likelihood of doing a really good resection is just not very high, because you just don't do it enough. And so that's going to be a really important thing. The other thing, I would just, have a conversation with a surgeon and are they confident that they're able to do something to help you? It doesn't mean they have to tell you that they're 100% sure that what they're going to do will work, because that's never going to be the case. And in fact, I'm a little bit hesitant when a surgeon says they're 100% sure that something will work, because I have not been, other abdominal endometriosis, I'm sure, but in many kind of pelvic pain conditions, I think you're not ever going to be 100% sure of anything in particular is going to absolutely work. But in general, I think you just have to speak to someone and see if you have their confidence, or they have your confidence. If you feel good about it, they seem knowledgeable, they seem thoughtful, they answer your questions in a thoughtful way, and they do what you need done frequently, then I think it's probably a good person to work with. The one thing I like to say is that find a doctor you trust and then trust them, which means focus on finding a doctor that you want to trust and then allow their knowledge to drive your care. I think that sometimes patients who want to make sure that everything's being done right in their case sometimes have a harder time trusting the doctor's expertise, because they want to make sure every little thing is exactly correct. And that can actually be a little bit more difficult, because there's a lot of different ways to do things. And so a lot of times you just have to find a doctor you trust and trust their judgment and experience to take the best way forward.
Another question we have is, if a non-painful mass in the abdomen on the lower right side could still be endometriosis. I have confirmed widespread endo throughout my pelvis.
If it's not painful, it probably is not endometriosis. I don't think I've ever seen an abdominal wall endometrioma that wasn't painful. Now, if you're on like high dose progesterone, or if you're on Lupron or Orlissa, like maybe it wouldn't hurt during that time, but even then, it's usually painful. Even if you're on suppression, usually abdominal endometriomas are really painful. Specifically, that person, if you were to send me an MRI or a CAT scan of that, I could tell you if I thought it looked like endometriosis. It's pretty characteristic. It's particularly on MRI. Like I think that axial, which are like those sausage cuts of MRI, are quite diagnostic of abdominal wall endometriosis. So, but the fact that you have confirmed widespread endo in your pelvis certainly puts you at risk, but usually it would be painful. You want to read some of these other questions?
We have another question. Can endometriosis implant in the abdominal wall during a peritoneum laparoscopic excision surgery?
Well, hopefully not. I mean, it can if the surgeon drags the tissue through the abdominal wall. Otherwise, it was probably there from the beginning. Like people can have abdominal endometriosis that was there from the beginning, just like the disease in the pelvis was probably there from the beginning. So, I suppose likely no. I mean, hopefully, if somebody's a good excision doctor, they're not dragging endometriosis through the abdominal wall. Hopefully, they're bringing it out through a sleeve or in a bag or something. But in theory, it can, but hopefully not.
Have you operated at the same time during LAP-X for severe endometriosis, along with the removal of AWE or umbilical endometriosis?
Yeah, frequently. If I have a patient that has abdominal endometriosis and they have a really good story for not having pelvic endometriosis, I might just remove the abdominal wall one. Like umbilical, no, but like if a patient has had 5 children and they never had symptoms of endometriosis and now they have an abdominal wall lesion, I'm going to assume that it's from their cesarean section and it's not because they have bad pelvic endo. And I'll probably just remove the abdominal endometriosis because that patient's a little less likely to have endo, also because she had 5 kids to some extent. Although obviously it's not absolute, but relatively. But if somebody has symptoms of pelvic endometriosis and now they have like an umbilical lesions, particularly spontaneous, like where they didn't have a previous surgery, are going to be frequently characteristic of bad pelvic endometriosis. I think that if you have a spontaneous lesion in your abdominal wall that wasn't put there by a surgeon accidentally, you probably have bad pelvic endometriosis. Just like if you have a lesion up in your diaphragm, you probably have bad pelvic endometriosis. And so in most cases like that, I would do the pelvic surgery, and then I would probably do the abdominal wall surgery at the end. Because if you remove the abdominal wall surgery, abdominal wall endometriosis first, it's just a technical issue. It's going to be hard to develop a pneumoperitoneum full of gas because you're going to have basically disrupted the abdominal wall in doing it, and now your gas might leak out. So you're going to do the pelvic surgery first, and then when you're all done with that, then you're going to do the abdominal wall surgery, but you can do it all at once.
So another question we have is, can AWE cause abdominal wall hardening? I'm experiencing hardening and I feel a large mass by the area surrounding that is hardening.
Well, there's a lot of reasons why abdominal wall could be harder. The question is there really a mass? So these kinds of lesions can be seen on imaging. They're quite characteristic on MRI, and on CAT scan usually can be seen also. Like if it's a really hard circumscribed mass, then it's something. It could be endometriosis. Again, usually endometriosis is going to be hard. I mean, it's going to be painful. Like if it's not painful, I would have some skepticism that it's endometriosis. If there is a mass there, the first thing to do is to see a doctor and have them look at it. I mean, there's lots of things that can be masses in the abdominal wall. I mean, endometriosis is one, but can be, even a cancer like sarcomas, which is a cancer of the soft tissue, can be in the abdominal wall. Like I was saying about how some general surgeons will biopsy the thing and say it's not cancer, and then they stop caring about it. It's like, well, it could be cancer. That's why they biopsied it. So that's not common. But if there is a palpable mass in the abdominal wall, somebody should look at it, and that might involve a physical exam, might be getting a CAT scan, might be getting an MRI, might be biopsying it. In my practice, like if it really clearly is abdominal endometriosis, I don't bother to biopsy it because I know what it is. But if you have a mass that you don't know what it is, it's very easy to take a little local anesthetic and this little thing called a true cut biopsy, where it's like a little sleeve that goes against the mass and it fires out a little needle and takes a little chunk of it. You send it to a pathologist and they can tell you what it is. So again, for Jill Williams, it's hard to say without examining you specifically, but in general, AW can cause abdominal wall hardening, but it's not the only thing that could.
The second part of her question was, can there be a cluster of AWE nodules, or do they typically present as one larger mass?
Yes, they absolutely can be clustered. I've seen that before, particularly in post-cesarean ones. I've seen sort of multiple lesions in one thing. Let me see, I probably have a picture of that somewhere. Let me see. I know I have one somewhere, but I do, but can't find it at the moment. But yes, the answer is it can present any old way. I mean, you can have, oh, there we go. Let me share my screen again. So this is a person that had abdominal wall endometriosis and multiple different lesions, all came out of the same incision. And this is actually I think this is actually the same patient that had that other lesion that was on her uterus. So she had pretty severe, quite severe disease. You know, particularly if the lesions got there iatrogenically, which means that a surgeon implanted them there, you know, whatever mechanism led one lesion to be implanted could certainly lead to multiple lesions being implanted. In most cases, they're kind of all clustered together and they come out all in big one piece, but you know, in theory, you could have multiple.
Okay, so we have another question, and it is, I have abdominal wall endometriosis, but I've never had a previous surgery or C-section. Is there a way to treat this? Is it common? And what does it mean for my endometriosis?
Well, yeah, absolutely. There's a way to treat it. Typically, we would remove that lesion either laparoscopically or through an open surgery. That particular lesion is, in general, it's very effectively treated if you have the right kind of surgery. As far as what does it mean for the pelvic endometriosis, you know, endo presents so differently. It's such a wide variety of ways that it can present. I mean, I would take typically people that have a spontaneous abdominal wall lesion usually have pretty significant disease in the pelvis. And so I would have to speak to that person, you know, personally and maybe do an exam and get a sense of what's going on or look at some imaging. But if the person never had pelvic surgery, then they very well may have significant pelvic endometriosis also. But it doesn't have a prognostic, meaning it doesn't predict the future, the fact that this exists, but it is generally a predictor that they probably have pretty significant disease in the pelvis, or they did perhaps prior to a surgery.
And one of our last questions is, what is the best post-op treatment plan?
Well, in the case of abdominal wall endometriosis, I don't think suppression is important because I think that you're really getting widely around the disease. I think there's some controversy in the pelvis. I think that doing suppression after pelvic excision, there are certainly some arguments for why that might be a good thing to do. But for abdominal wall endometriosis, I don't think suppression is important at all. I think if you really widely get it out, then you're really taking care of it. So at that point, it's just a matter of recovering from the surgery. So in some cases, you have to wear, if we're concerned about, if we put a big piece of mesh and we want them to not put a lot of stress on it, we might have people not lift heavy things for 6 or 8 weeks. We might have people wear an abdominal binder. In some cases, we put drains in and you have to manage the drains for a few weeks. And then after that, pelvic physiotherapy or any kind of working with a physical therapist, I always think is a good thing. I mean, you know, no orthopedist, like if an orthopedic surgeon did a knee surgery and did not put that patient in PT afterwards, they would be committing malpractice. And yet we consider pelvic PT to be sort of optional. It's like, I think if you want the best outcomes from endometriosis surgery, you should be doing pelvic PT before and after surgery. And I think the same can be said for, you know, abdominal wall, because it's just a matter of, you're getting scarring. Anytime you operate, you're going to get scarring. And the more you can keep things moving and keep things strong, I think the better the tissues are going to heal. So I think PT is important.
So thank you so much, Dr. Fogelson, for taking your time out of your day to share your knowledge with all of us. And thank you everyone for joining. And I hope that the rest of you all have the great rest of your day.
Thank
Bye.
you guys so much. If anybody would like to speak to me directly, we have my website is endometriosis.com. I'd be happy to talk to anyone that either has AWE or other endometriosis issues and be happy to help. And my associate, Shanti Moling, is also an awesome surgeon, great doctor, and be happy to help as well. Okay.
Have a great rest of your day. Thank you again.
Thank you very much. Bye-bye.
Bye-bye.